So before we close, I think we'll talk about another very important syndrome, Zollinger-Ellison syndrome. Can someone type what is Zollinger-Ellison syndrome quickly without Googling? What is Zollinger-Ellison syndrome? Hyper? Oh, very good. Who did that? Yes, very nice. That is the answer. So Zollinger-Ellison syndrome, ZEES, short from ZES, ZES. Here, there are ulcers, there are triad is there. They should be ulcers, they should be tumor, gastrin secreting tumor. It can be in the pancreas or it can be the duodenum itself. Zollinger-Ellison syndrome is a triad. One is acids, ulcers, tumors, and you have to have an evidence of hyper secretion of gastrin. The gastrin level should be more. If you have these three, your diagnosis is ZES, Zollinger-Ellison syndrome. There is no medicine. They also present like this: upper abdominal pain, vomitings, acidity, GERD symptoms. So when do you suspect ZES? Zollinger-Ellison syndrome is not very common. It's a very rare. When, as I told you, the duodenal ulcers are common in first part. If 95% of the ulcers occur in first part, if somebody having ulcers in the second, third, fourth part, or they are not responding to conventional medical therapy, you suspect the Zollinger-Ellison syndrome and investigate. And what is the treatment for Zollinger-Ellison? This is only surgical treatment. You have, of course, you give PPIs, but the curative eradicative therapies, your gastrin secreting tumor has to be removed either from the pancreas or from the duodenum. That is the surgical treatment of Zollinger-Ellison syndrome. The patient will have diarrhea, patient will have pain abdomen, patient will have acidity, epigastric tenderness, and the conventional methods of treatment will not help in this. So if you are coming across any kind of situation like this, you suspect Zollinger-Ellison syndrome. They are benign. They are gastrin secreting tumors. Okay. Lastly, we will talk about the stress mucosal damage. The gastric mucosa also can get damaged because of the acute stress. Somebody has sepsis, somebody is admitted with some burns, or somebody is admitted with say shock, septic shock, sepsis, septic shock, burns. They get this stress related mucosal injury. Usually they don't cause ulcer, but they can cause bleeding, stress induced bleed. So that's why by habit we give the pantoprazole or omeprazole to all patients that are coming to our hospital, which is not a good practice. It's good you have to protect the gastric mucosa, but then every patient doesn't require these PPIs. You should be choosy and you should be selective in deciding, because there's a lot of side effects for these proton pump inhibitors. Suppose somebody has head injury, somebody has a trauma, burns, shock. These people, because of stress, they can have this stress-induced mucosal injury, and sometimes they may have hematemesis, or sometimes coffee colored. When you put a rhinestone and aspirate, you may get a coffee brown color aspirate. That is the stress-induced mucosal injury. Here, there is no inflammation. There is no inflammation. There is no ulcer. So therefore, long-term treatment is not necessary. Once the stress is taken off and the patient is discharged from the hospital, you don't need to continue these PPS a long time. That's why we should not call this a stress-induced gastritis. There's no gastritis here. We should not call it as a stress gas. We usually write stress-induced gastritis. No, this is stress-induced mucosal injury, because there's no gastritis. As I already said, if you want to call gastritis, it should be proven by histological methods. So this is a misnomer actually. Stress-induced gastritis is a misnomer. There is no gastritis. Stress-induced mucosal damage or mucosal injury. I think now we'll stop here and take a couple of questions from anybody.
How to differentiate clinically that the gastric outlet obstruction is due to pyloric stenosis or the edema due to
Edema? Clinically, it is difficult. Obstruction is obstruction. Clinically, only endoscopically you can differentiate. So edema usually doesn't produce that much of obstruction. And when you do endoscopy, you will know what is that you are dealing with.
So when do we do RUT, rapid UTI?
Yeah. Usually, whenever you are suspecting a chronic acid peptic disease, if somebody is presenting to you with a recurrent symptom for months and years, and especially when endoscopy, you have a ulcer, gastric or duodenal, and most of the time it's a very simple test. You can just take a small bit of mucosa and do a test. The results are out and within seconds, or not more than 1 or 2 minutes. So it's very simple. Rapid urease test is confirmatory of a H. pylori infection. But again, whether to treat all patients with positive rapid urease test, there will be a big question to be discussed.
How to decide whether to give PI along with NSAID in patients with pain and inflammation?
Yeah, usually, yeah, it's a good question. There's no one, there's always a gray zone here. There's no one sentence answer. Which patient will react badly? So, non-steroidal anti-inflammatory drugs are very commonly used drugs. They're painkillers. You have to give them. But who will have complications? Who will have bleeding? Who will have ulcers? We don't know. So, some people believe that every time when you are giving NSAIDs or even aspirin, you have to give the proton pump inhibitor, but some people don't believe in that. Right? Why should I give? So it's a little gray zone actually. Better to avoid these NSAIDs as much as possible. Best thing is your paracetamol is a very good painkiller. Your tramadol is a good painkiller, and the combination is excellent. You get Ultraset in the market. There's a combination of paracetamol and tramadol. They are very safe. They are gastric friendly painkillers. But somebody wants to give aspirin and non-steroidal anti-inflammatory drug, you have to keep this complication of gastric mucosal injury in mind.
So chronic gastritis and ulcer, are they two different entities?
Yes, chronic gastritis. I have not touched upon. Probably, if time permits, tomorrow we'll talk about 10 minutes about chronic gastritis. I have not touched that part. It's a very big topic. Actually, I'm cutting it down for your sake only because you are all undergraduates, most of them. I'm cutting down to minimum required for you. It's a very big. You can have a one-day conference about the acid peptic diseases. So the microscopic mechanisms and all those are fantastic biochemical mechanisms. Okay. If there are no questions, I think we'll stop here. Thank you very much once again for your patient listening, and see you tomorrow. Good night. Take care. Bye-bye.